From the JAMA Network, this is JAMA Otolaryngology Head and Neck Surgery Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Otolaryngology Head and Neck Surgery.
Hi everyone, welcome back to the JAMA Oto podcast. I'm Paul Bryson, your web editor. Today I'm joined by Dr. Michael Brenner from the University of Michigan, Department of Otolaryngology Head and Neck Surgery. Today we're going to cover a range of topics, specifically liquid biopsies for head and neck cancers, and also touch upon the emerging technology of circulating tumor DNA. Welcome to the podcast, Dr. Brenner.
Delighted to be here. Thanks for having me, Paul.
Well, we're really glad you joined us. We know that you and your team recently composed a comment in the journal about liquid biopsies for head and neck cancer. And I was hoping, before we dive into that, if you might be able to provide the listener just with a high-level current state of affairs regarding this emerging technology with liquid biopsies, what they are, circulating tumor DNA for head and neck cancer. These are things that our listener may be aware of, but maybe could benefit from some more details.
Thanks so much for the invitation to speak on this topic. And so, in terms of just a high-level view, there is a growing recognition of the need for better ways to both diagnose and provide surveillance for oropharyngeal squamous cell carcinoma, and frankly, all head and neck cancers that we deal with in otolaryngology. And the current approaches that we use that are dictated by the National Comprehensive Cancer Network, they recommend standard care that involves examinations, history taking, along with imaging at 3 to 6 months, and then additional imaging and treatment as the team's discretion. And the trouble here is that a lot of the time, the initial presentation or detection is delayed. So often it's prompted by symptoms that patients may have or by an incidental imaging finding. And so that's led to the desire for better approaches to both detect and follow up on these tumors. So current surveillance standards are limited, and there's now this interest in the use of liquid biopsies that allow us to basically use some sort of evaluation either from saliva or from most commonly from blood or from urine to try to understand whether there is DNA present that can detect the presence of tumor. So would it be helpful if I elaborated a little bit on how these assays work?
Yeah, I think so. And, one question that comes to mind are there any other solid organ tumors or models that currently employ this technology?
Yeah, so there are actually several other tumors where these types of technologies are being studied. So there's work on liquid biopsy in thyroid cancer, as well as in lung cancer and several other malignancies. And so in the case of human papillomavirus, oropharyngeal squamous cell carcinoma, basically what we're looking at is circulating tumor DNA. So it's nucleic acid fragments that are released from malignant cells. And this happens in two ways, both passively from necrosis as well as actively when there's exocytosis. And the thing that these assays are specifically evaluating is the E6 and E7 oncoproteins of the human papillomavirus, because those suppress the activity of the host tumor suppressor proteins, P53 or retinoblastoma. And that inhibition of tumor in turn results in the unchecked progression of cell cycle and accumulation of genomic aberrations. So what was really interesting was in the recent article in JAMA Otolaryngology, Ferrandino and colleagues, they looked at the real-world performance of these plasma tumor tissue modified viral assays that are based on that technology. So this became commercially available in 2020, and now we're seeing what the actual results are. And they've been notable. In that specific study, they had 100% specificity in diagnosis and surveillance. The sensitivity was a little bit lower. They had a diagnostic cohort and surveillance cohort that had a 91.5% and 88.5% sensitivity, respectively.
I mean, it's pretty impressive for emerging technology. What did you feel like the limitations were in the study, and how did you internalize it as getting ready for prime time or adding to some of the surveillance methods you were able to describe earlier?
Right. So, as with any technology, It takes time to figure out how it's going to be applied, when you should be deploying it, doing the test, as well as how to interpret that information. So, for example, if you were to identify the presence of tumor earlier, but the ability to treat earlier didn't translate into improved outcomes, then you've basically created a lead time type bias where the patient is living with the disease for longer, but not necessarily improving how they fare with it. It's also possible that if you get a negative result and the patient actually has disease, that if you have over reliance on that study, you might step back from other things, whether it's history, physical exam, or other imaging, that would tip you off to the presence of a malignancy. But there are also some bigger questions that are really relevant. So, in addition to the basic question of whether this actually confers benefit, there are questions about what is its predictive power. So, for example, you might be able to tell if there's presence of disease, but it doesn't tell you anything about how advanced that disease necessarily is, because some tumors will shed more prominently than others, although obviously a bigger tumor burden has some correlation. But the other thing is it also doesn't give you any information about how the patient will respond to therapy. Of course, it also doesn't have direct therapeutic potential, being a biomarker that would trigger other evaluation and or treatment approaches.
No, I appreciate that explanation. That makes sense. What I'm hearing is we need to figure out how it fits into the portfolio of monitoring and maybe try to see how it plays out with response to disease. I think that's one of the important things, right? Trying to predict with more specificity how a given patient might respond to treatment.
Yeah, that's exactly true. It's still very early as a technology. There have been some fairly large studies. For example, there was one that involved over 100 centers that looked at what the positive predictive value of it was. And those promising data do suggest a role for this technology. One thing that's especially exciting and that they've been looking at my institution is developing assays that can look at that HPV DNA within urine. So you think about considerations of access to care, so access to either a blood draw or a facility to process it. That's a way that you can improve your outreach. There's also some considerations of approaches that are different from HPV cancer detection. So obviously, if you're relying on the unique signature of HPV carcinoma, then you're not going to be able to detect squamous cell carcinoma or other mucosal disease that doesn't have HPV involved.
Yeah, I noticed that in the title. What's your sense for liquid biopsies? Is there hope for non-HPV related disease?
I think there is. We're early in this process, and the comments that we made in that article are really a credit to the work of a incredibly talented senior resident that we have, Josh Smith, as well as work being done in the lab of Steve Chin that have been studying the tumor immune microenvironment. But basically, the idea is that you can use plasma tumor-derived extracellular vesicles. So these are sometimes called exosomes, and essentially there are these small lipid bound particles that are chronically constitutively being released by malignant cells. And they harbor a lot more than just DNA. So they have DNA, RNA, microRNAs, and they have protein cargo like receptors and enzymes. So you get this potentially more panoramic view. It's almost like a more comprehensive biopsy of that tumor because there's more material that can be evaluated. And these are present in saliva and urine and plasma. And so they can be isolated at any stage, much like you can take the HPV based assays, so before, during, or after treatment. And so if you use this type of approach, then you might get information on responsiveness. And there is some work that's been done where essentially you isolated these extracellular vesicles from individuals who were cancer patients, and then you looked at surface PD-L1 expression, and then that was able to predict disease recurrence and treatment response in certain HPV negative populations.
Well, it'll be interesting to see how that evolves. It sounds like the platform modifications that would be needed, they don't sound too insurmountable, and it sounds like a lot of that foundational work is already occurring.
There are actually a series of stages in biomarker development, and certainly the commercialized assay that's being used for HPV positive oropharyngeal squamous cell carcinoma is further along that pipeline. But it's pretty striking that when you look at, for example, PDL1 carried by exosomes in studies of human subjects, you can basically see that that marker correlates within these extracellular vesicles with disease activity, with the TNM stage, with nodal status. So, in contrast, when you looked at plasma levels of serum PDL1, that didn't correlate with those clinical pathological parameters. So it's a potentially more powerful tool in terms of the information that you're getting and its physiologic relevance, but it doesn't yet have the same level of sensitivity and certainly doesn't have the mass adoption.
Yeah, as you look ahead, are there any open trials or open things that you're excited about with some of this technology? What does the intermediate term look like with some of these investigations?
There are a lot of studies that are underway, and gathering prospective data using standardized protocols is going to be extremely valuable in understanding the appropriate value and application of these technologies. It's going to move faster in the case of HPV DNA just because you have an assay that's more mature and that's overcome a lot of the practical barriers to adoption. The cost is going to be a significant factor as well for any of these types of assays. At our institution, the assay it's billed through insurance and they have a fairly elaborate process where they go through appeals and then figure out how to handle the expenditure, but effectively avoiding patients bearing that burden. But we don't really know yet, again, whether it is really going to improve their prognosis, outcomes, or treatment at this point, but certainly that's the anticipated goal. And the ability to open it up beyond HPV, oropharyngeal squamous cell carcinoma, is a huge opportunity for our field and could really be transformative.
Well, I really appreciate you providing this background and update and talking about the potential of this technology. Speaking for myself, I don't encounter this in my current practice very much, and so it was really valuable to hear about what the landscape looks like for this. As we wind down the podcast episode, what are some take-home points for the listener? Anything you wanted to emphasize before we conclude?
Yeah, thanks for inviting the opportunity to add some closing comments. One of them is that with the adoption of any new technology, there is potential for both help as well as harm. So, having a thoughtful approach to assessment and adoption is critically important, and doing it in a way that is structured and purposeful as opposed to haphazard is really key. So, in doing that, having defined protocols that allow for clear measurement and assessment with agreed upon outcomes across studies is going to be incredibly helpful. Patients should be offered the opportunity to enroll in these trials. So, to the extent that institutions can engage in these collaborative efforts, that's going to be extremely important. And when we think about these tumor derived extracellular vesicles and their emerging role for the whole subset of non squamous cell carcinoma, the key thing there is probably to realize the value of the translational scientists, all of those scientists, both our colleagues, whether they're clinician scientists or basic laboratory investigators, in pushing that field forward and allowing us to explore the new possibilities because there is really a broad landscape that will allow us to achieve new benefits for our patients, both in screening, surveillance, as well as definitive cancer management.
Well, Dr. Brenner, I really appreciate your time, and it's been great to have you on the podcast. I'll certainly be keeping an eye on your work, and maybe we'll get to do this again sometime soon.
Hey, thanks so much. The pleasure would be all mine. Thanks so much, Dr. Bryson.
This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening.